So hello, everybody, and thank you very much for joining us this afternoon. This, I think, is going to be a great session, and I know it's a bit of a different time frame that we're used to, but this is I think this is a good time also for the guys in New York. Vikash, can you hear me?
Yes, I can.
Great. So I'm going to turn over the podium to you to introduce the speaker, and thank you all for joining us.
Great. So it is my pleasure to introduce our Grand Round speakers for today. It is Dr. Haviva Veller. She did the majority of her undergrad, medical school, residency training in Israel prior to doing her fellowship at the Children's Hospital of Philadelphia in sleep medicine. She then joined the Montefiore group and was there for a brief stint before she joined our faculty here at Cornell in 2010. And within a couple of years of arriving here, she established our sleep center. And that really helped progress our sleep program here. She's on the cutting edge of a lot of initiatives that we've done. Sleep medicine in kids has changed a lot in the last 10 years. Everything from drug-induced sleep endoscopy to endoscopic airway surgery. These are things we didn't do as much before, but with the help of Dr. Veller and her sleep lab and her collaboration with our craniofacial team, we've really taken things pretty far here at Cornell. So thanks, Aviva, and look forward to your talk.
Thank you very much. It's a pleasure to talk to you this morning, and I'm gonna share my screen. All right, can everybody see my screen?
Yes, looks great.
Okay, great. So good morning, and much for inviting me. As Dr. Modi said, I'm one of the pediatric sleep physicians at Cornell. I'm directing the center, and I'm very excited to talk about sleep in children because I think it's probably one of the most important things that they do. So what I thought is we should start with a case which explains a lot about how we handle those cases of pediatric sleep apnea. And the kid that we present today is an 11-month-old baby that presented to ENT with a history of snoring and adenoid hypertrophy. And 11-month-old, it's not a usual age for snoring or the whole picture of obstructive sleep apnea. And also because of the unusual presentation, the decision was made to send him for a sleep study. And I'm going to walk you through all those wiggly lines. What you see here is a 5-minute epoch of a sleep study. On the top, that's the EEG measurement, which helps us score sleep. But when we talk about the respiratory channels, you can see that we have the chin EMG, which measures the muscle tone. And I'm going to jump down to the snore microphone. And you can see in both of them, you can see the kids is snoring pretty loud, pretty significantly. Again, unlike what we would expect from 11-month-old. You can see the right below, there's the oxygen saturation line. Down here are the way we measure the flow, the way the child is breathing. We have 2 measurements of flow. We have the blue line, which shows the pressure flow, and the pink line that shows the thermistor or change in temperature flow. Just underneath that, we have the chest measurement and the abdominal measurement, so the work of breathing that goes with the flow. And then on the bottom, we have the CO2 measurements. We have 2 ways we measure. We measure entitled CO2, which is a second-by-second measurement at the end of each breath. And we have the transcutaneous CO2, which is more of an average CO2 levels. One thing I will tell you, if you look at the entitled CO2 measurements, you can see that they kind of look like a picked mountains, and they don't get the plateau that we usually would like to see with entitled. And that's because children, younger children, they breathe fast. They never reach their the
You seem
nice
to have
plateau in
lost
the
the
entitled.
voice, Michael, on this side. Can you hear things?
I'm sorry, say again?
No, we're hearing it fine.
Oh, okay, we just lost it for a few minutes. Sorry.
Okay.
All right. Are we good?
Yeah,
Yeah.
I think we're good.
Yes.
Good to go. Okay. All right. So my point here is the measurements with the two values, the end-tidal and the transcutaneous, they kind of supplement or complement each other. We find that actually the transcutaneous CO2 measurements are much more accurate in the younger kids. Something to think about. Not every sleep lab will have that measurement. All right. So what you'll see over here is that the kid had pretty much regular breathing, right? You can see on the flow measurement that the breath, this is a deep sleep measurement, and you can see that each breath really looks exactly the same as the previous one, and they're coming in a regular rate. So the only two things that kind of jump out of this screen is the loud snore that we wouldn't expect from an 11-month-old. And when you look at the chest and abdomen movement, you can see that instead of moving together, they move against each other. That's what's called paradoxical breathing, the chest and the abdomen moving in two different phases. But that, again, could be normal for an 11-month-old. However, when we moved forward into the study, into the night, this is a different sleep stage. You can see that the picture is completely different. You can see that when we look at the flow channel, you can see that this kid has very clear apneas. You see, there's no pickup on the flow channel, and every few seconds he has those gasps or kind of big breaths. Where he wakes up, he kind of corrects the breathing, and then he goes back to another episode of apnea. Again, two big breaths, and then another episode of apnea, and it happens again and again and again. And this is what you look now at 5-minute epoch, and you can see that it happening the whole time. Again, you can see when you look at the chest and abdominal movement, you can see that they're out of phase, but they're even more exaggerated. So the kid is trying to open the airway, but he's unable, and he keeps obstructing the airway. So this is sleep apnea, right? This is how it looks like. You have the no flow and the persistent movement in the chest and abdomen. And the results of the study overall showed severe obstructive sleep apnea with apnea-hypopnea index of 88 per hour, which is really high for such a young baby. He had desaturation to a nadir of 83%. He had hypoventilation with the max end-tidal CO2 to 58 torr and overall sleep fragmentation. So we said the kid had big adenoids. So the next step will be to take out the adenoids, and he really had adenoidectomy. And on the follow-up, after the few months after the surgery, the family came back and said the kid is still snoring. You know, maybe it got better after the surgery, but he's still snoring. So in this case, again, we send him to have another sleep study to see what is going on. And you're already expert in looking at sleep studies, and you can see that this kid has persistent obstructive sleep apnea. Again, you can see those very long pauses in breathing with gasping, with corrective breaths. And again, another episode of obstruction and another few breaths just to correct. If you look at the line of the oxygen, if you can tease out the oxygen line, you can see that when the kid is going into his apnea, he's desaturating. It starts from mild desaturation to 95. Over here, it goes down to even lower. But when he takes those 3 or 4 corrective breaths, he corrects his saturation back to where it should be. One more thing I wanted to show you is the this is an overlook over the whole sleep study. Before I showed you kind of a representative 5 minutes, over here it's kind of the whole study. The upper panel looks at the different sleep stages, and this kid and typically to our other younger kids, this kid had great sleep. You can see what you see here is he started with a deep sleep. That's the dark black line at the bottom. Every time we have dark black line at the bottom, the kid is in deep sleep. The red lines are when he's in REM sleep, and the blue lines is when he's awake. Besides kind of a little bit of fragmentation here and there where the kid wakes up but he falls right back to sleep, the kid had beautiful sleep. So the sleep threshold in young kids is high, and looking at awakenings is not always the way to assess their sleep. But what I really wanted to show here is if you look at the red line at the bottom, this is his oxygenation. And what you see in obstructive sleep apnea is there's no persistent decrease in oxygen saturation, but you get those ups and downs in the saturation. So in times of the night where the kid does not have that much sleep apnea, like when we see during deep sleep, you can see that his oxygenation is perfect. It's very close to 100%. But during certain times throughout the night, you can see those dips into lower saturation. And what you see is they pretty much correlates with REM sleep. And we know REM sleep puts the kids in risk for sleep apnea because during REM sleep, we have muscle paralysis. So second sleep study for this kid showed, again, severe sleep apnea. There's much improvement, right? It was apnea-hypopnea index was 88, now it's 32, but it's still severe for children. Desaturation to 77%, sleep fragmentation, pretty significant. So what are we doing? What should we do now? So next step will be to, again, he underwent ENT evaluation. The decision was made to do a total adenotonsillectomy and pharyngoplasty. That was done, and we repeated the study again to make sure that there's complete resolution. And here are the results. And again, you're expert, you can see that this kid still had persistent obstructive sleep apnea. Again, you can see the pauses in his breathing with corrective breaths. I'm sorry. At this point, again, there was significant improvement from the previous study. His apnea-hypopnea index decreased to a third of what it was. So now it's 13 events per hour. Still severe in pediatric criteria, but much improved. Desaturation to 87%, so improvement on the desaturation, and sleep fragmentation. Now what do we do with this kid? Obviously, he needs treatment. He's not cured. Well, what will be the next step? So next step will be to do the drug-induced sleep endoscopy, or DISE. We know it's a relatively new procedure where there's an effort to create almost a sleeping situation. So very light sedation, not full anesthesia where all the structure or the muscle tone is down, but just a light sedation, and kind of try to mimic sleep and see what happens in the airway during sleep. Because we know things change in the airway when kids sleep. So what was found on the DISE is that there was hypopharyngeal collapse with palatal collapse, micrognathia, and glossoptosis. All abnormalities that cannot be really corrected with surgery. So what will be the next thing? What will be the next treatment for this kid? This is his last sleep study. You can see that his oxygenation and breathing is more regular. So we initiated CPAP and we titrated him, and with using CPAP at a pressure of 9, he had normal oxygenation, normal breathing, and that was the way that we eventually treated this kid. So when we talk about pediatric obstructive sleep apnea, which is a different entity than adult sleep apnea, the prevalence of snoring is about 10% in the general population. And you know that because you always ask about snoring in your history. Many of the families will say, my kids snore. And of course, you always ask about significant snoring. You ask about loud snoring that is there at least 3 times a week, persistent for the last 3 months. Because usually the parents will report about snoring that happens when the kid is sick or when during allergy season. We really want to be more specific and find out that it's more persistent. Obstructive sleep apnea is prevalent about 1 to 5%. I think it's closer to 5%. Again, it depends on how you diagnose it. It's much higher in high-risk population, and we'll talk about them later, but you see that definitely kids with obesity and kids with genetic or craniofacial abnormalities, we see the sleep apnea much more prevalent. The reason we treat sleep apnea is really because of the complications. In pediatric, the short-term complication, and probably the reason that we're so keen about diagnosing and treating it is the neurocognitive impairment. And what you see here at the graphs on the side, it's kind of the classical research that was done that looked at two groups of kids. You can see the kids with obstructive sleep apnea in the pink line, the control group, no sleep apnea on the blue line. This panel shows that their apnea-hypopnea index was higher, the kids that with OSA compared to the controls. This is behavioral studies that were done. This was Connor's hyperactivity study. That was the a cognitive assessment study, and this is the daytime sleepiness. And you can see that significant change or significant decrease in function in terms of hyperactivity and cognitive function in the kid with the obstructive sleep apnea, with nice correction after surgery, after their AHI was corrected. You can see that the correction is significant in the sleep study, as well as the daytime sleepiness. There's still not perfect correction in terms of the hyperactivity and the cognitive function. So neurocognitive impairment, behavioral problem, learning difficulties, mood disturbances, these are the things that we see right away in the children. And it's so important to diagnose in children because the learning curve is very steep. And if they stay behind, they get labeled with ADHD or with learning disabilities, which are labels that are very difficult to get out of. So this is our role in helping them get out of that cycle. Secondary enuresis, definitely we see with obstructive sleep apnea. And then the more long-term complication that are seen much more in adults than we see in children are the cardiovascular complication. In adults, we will see the hypertension and left-sided heart failure. In children, we see more of the cor pulmonale. Again, I saw it in kids that had many years of pretty severe sleep apnea, mostly in the Down syndrome children and in children that have already underlying heart diseases. We see metabolic changes. Again, we always think about sleep apnea as I call it plumbing. You know, we have a tube that is obstructed and we need to fix it, but it's not true. We know that sleep apnea is it's an inflammatory, heightened inflammatory status, and that high inflammation causes other metabolic changes like high CRP. We see the because of the constant stress overnight, we see insulin-resistant diabetes, we see hyperlipidemia, and we see further increase in weight. Again, all of this due to the ongoing stress overnight. In children, we see impaired growth. Again, in adults, we will see the increased weight gain, and truly physicians that treat obesity will send me these kids to confirm that they don't have obstructive sleep apnea, because if you have obstructive sleep apnea, you will gain more and more weight. In younger children, we see the decrease in growth. We see the failure to thrive. And then overall, there's increase in healthcare costs for everyone. So what are the risk factors for a child with obstructive sleep apnea? Pretty much adenotonsillar hypertrophy takes the first, second, and third high risk causes, but we also see it in other comorbid conditions, like in craniofacial abnormalities, genetic syndromes, neuromuscular weakness, children and obesity, and we'll talk more about these groups. So these are really our kids that are at high risk for obstructive sleep apnea. And these are kids that will have incidence between 50 to 100%. And we already talked about obesity. Obesity, we know, causes obstructive sleep apnea in multiple, because of multiple causes. Not only the heavy, the fat layer or the heavy weight that they have on their chest or on their neck, but we know that fat infiltrates the upper airway and causes narrowing of the upper airway because of the infiltration of the fat tissue. Um, um, Kids with Down syndrome, which will have, by adulthood, where probably 100% of them will have sleep apnea. With Down syndrome, we know it's multifactorial. We know that they have the low muscle tone, they have the obesity, and they also have the facial deficiency, the mid-facial hypoplasia. So all these will cause them to have significant, and the macroglossia sometimes. Patients with Prader-Willi, again, significant obesity, but also the control of breathing is not fully there. Patients with skeletal dysplasia, in our center, we see many of them because of the proximity to the hospital for special surgery. Many of them will have, again, craniofacial deficiencies, mid-facial hypoplasia, micrognathia. We have the patient with Beckwith-Wiedemann with the macroglossia, the patient with Pierre-Robin that have the small chin, patients with muscle weakness. Patients that have low muscle tone, again, when we fall asleep and our muscle tone decreases anyway, they will develop obstructive sleep apnea, usually with hypoventilation. And it's interesting because in the past few years, we've seen less and less of the Duchenne muscular dystrophy or the SMA, but we see more and more kids with cerebral palsy, right? With the improvement in treating premature baby, we have more and more kids that leave the NICU, unfortunately, with CP. And these are the kids with the neuromuscular weakness that will develop a obstructive sleep apnea along the way. Interestingly, patients with sickle cell anemia, the mechanism is probably these kids have non-functioning spleen, and the adenoids and the tonsils kind of compensate as immune tissue. And there's probably a compensatory increase in the volume of the tonsils and the adenoids, and that's their mechanism for obstructive sleep apnea. Aside of the fact that they have isolated hypoxemia because of their hemoglobin that doesn't release the oxygen well into the tissue. Again, we have the group of the craniosynostosis with the mid-facial hypoplasia, the Crouzon syndrome, Pfeiffer syndrome, Treacher-Collins. We have patients with spina bifida and Chiari malformation. So these are the patients that have their brainstem kind of slides down, get pressed by the midbrain, and depends on where the pressure point is, these patients will develop either obstructive sleep apnea or central sleep apnea. So it depends if the pressure is on the breathing center itself or on the nerves that leave and innervates the face. And patients with storage diseases where you have deposition of storage material in the upper airway causing obstructive sleep apnea. When we talk about more of the general population, where do we see higher risk for sleep apnea? So I already mentioned sleep apnea is an inflammatory state. It's an inflammatory disease. So when we have inflammation along the airway, there's increased risk of obstructive sleep apnea. So patients that have asthma, which is inflammation of the lower airway, or even patient with allergic rhinitis, which is inflammation of the upper airway, or recurrent sinusitis, these are the population that are higher risk for obstructive sleep apnea. African Americans have 2 to 4 times higher risk of developing obstructive sleep apnea. Premature infants, multiple reasons to develop sleep. You almost look at the premature baby and you say, how come it does not have sleep apnea, right? They have the low muscle tone, they have the thick neck, they have the structure of the upper airway almost calls for collapsibility of the upper airway. They have laryngomalacia, they have tracheomalacia. So 3 times higher risk for developing sleep apnea. Interestingly, in studies, prior adenotonsillectomy came up as a risk factor for persistent sleep apnea. And that's probably because we have, these are the kids that will have sleep apnea for other reasons, but the first pass or the first treatment will be taking out the tonsils and adenoids. And so the adenotonsillectomy almost unmasks the other reasons they have obstructive sleep apnea. Family history, definitely high risk for sleep apnea, might be because of innervation to the upper airway or structural abnormalities. And then sociocultural differences. So we see more sleep apnea when there's environmental smoke exposure, probably because of the mechanism is inflammation of the upper airways, recurrent infection, exposure to irritants. Sleep deprivation puts you at higher risk for sleep apnea. I'm not sure about the mechanism there. And then disadvantaged neighborhoods, low socioeconomic states. So if we talk about the difference in presentation between children and adults with sleep apnea, in the pediatric OSA, we pretty much see 2 phenotypes of sleep apnea. We have the younger kids that have enlarged tonsils and adenoids, and they are more the irritable kid with a failure to thrive, as opposed to the adolescent that most of the time the reason for their sleep apnea is the obesity. So in the childhood classic or type 1, we call it obstructive sleep apnea, we see that there's no gender difference. Males and females are affected to the same degree. The peak age is between 2 to 8 years, and you know that this is the time where the tonsils and adenoids are at their highest size or biggest size. Obesity plays a smaller role in here, and actually these kids will present with a failure to thrive because they use so much energy to breathe at night, they don't use it to grow for growth. So they will present to us with issues with weight gain. These kids will present with snore, but not so much with the daytime sleepiness. They will present with a hyperactivity and the learning disorders. Again, if any one of you that have kids know that when kids are tired, they don't slow down and doze off in the corner, they become hyper. So kids that are chronically tired will develop hyperactivity, and of course, they wouldn't be able to concentrate on a task or sit down to fulfill a task. So they will get labeled with learning disabilities. Again, threshold of sleep in a young age is very high, so arousals is not that much of an issue. The respiratory pattern, interestingly, is more of obstructive hypopnea or hypoventilation. The pediatric ENTs will know that when you get a report of the sleep study, our kids, I showed you at the beginning a case where a kid had apnea. We rarely see apneas on the sleep studies. Kids usually will have hypopneas, but hypopneas are can cause the same complication and the same consequences as apneas. It's just that the kids don't have full pause in their breathing. And in these kids, adenotonsillectomy is really the cure for their disease. If we jump over to the obese children, you can see that the adolescent or the obesity-related sleep apnea in children has more correlates with the adult sleep apnea. So again, over here we see the predominance in males compared to females, similar to the adult OSA. We see it in the teenager kids. Obesity has a major role in the OSA. These kids will present with snoring and either, again, their hyperactivity and learning disability, but they also present with the excessive daytime sleepiness. They will, when they come to my office, if I walk in a few minutes later, they're already sleeping there. Arousals happen frequently, and that's probably the correlation to the daytime sleepiness. They can have either the hypopnea or full apnea, like we see in adults. And the role for adenotonsillectomy is more of a question. So these kids definitely improve if they undergo adenotonsillectomy, but it not always resolve the whole sleep apnea. It causes improvement, but it doesn't cause a cure. So if we talk about a sleep study criteria, so sleep study also called polysomnography or PSG. So on my slides, you'll see the word polysomnography, PSG. It's still the gold standard for diagnosing sleep apnea. Again, children, especially young children, you don't always get the clear picture. They don't always have the daytime sleepiness. They don't always have the snoring. They don't always have the typical daytime symptoms that we expect them. Night-to-night variability is very small. That correlates is 80 to 100%, 85 to 100%. So many times when we have patients coming to the lab and the study is either very normal or very abnormal, and the parent said, "But we don't believe that at home. They sleep so much better." Usually, the sleep study does reflect what's going on in their night to night. And the severity rating that we use is, again, it's the apnea hypopnea index. So it's a sum of all the apnea and the hypopnea events divided by the number of hours that the patient slept. We like to use the obstructive AHI term and subtract or take out all the central events, because central is a different story. And this is the severity score that we still use. So apnea hypopnea index of 1 to 2 is very mild. 2 to 5 is mild OSA. 5 to 10 is moderate OSA, and more than 10 is severe. And the adult ENTs here will quickly recognize that the numbers are very different than adults, much lower than you see in adults. Other parameters that we measure, and of course, it's very important to decide which kid to take to surgery and which kid not to take the surgery, is the end-tidal CO2, so the effect of hypoventilation. And hypoventilation, we determine if more than a quarter of the night is spent with end-tidal CO2 above 50 torr. Arousal index is important, right? It indicates the sleep fragmentation. Believe it or not, we wake up 10 times an hour. It still amazes me, that number. Of course, we're talking about arousals. They are kind of picked up by EEG. They're very short, not always associated with body movement, but we see them on the EEG. And one of the new things that came out of the ADS is create criteria for what is significant hypoxemia, right? We look at the low saturation. We know it's important, but now there's a number. So significant or severe hypoxemia is when 5% or higher of the night is spent with saturation less than 90%. These are our measurements and how we approach the sleep studies. Again, usually we like to communicate the results of the sleep study by looking at the AHI or the apnea hypopnea index. But of course, there's so many more measurements that go into the decision of when to treat and when not to treat. And I'm going to be very deficient if I'm not going to mention one of the biggest studies that happened in the pediatric sleep, the CHAT study, or the childhood adenotonsillectomy study. And this is really one of the biggest studies that we're trying to determine what is the right timing for adenotonsillectomy and what are the consequences of delaying adenotonsillectomy. We know that in New York, if we have a patient with severe obstructive sleep apnea, we can get them into surgery relatively quickly. But in other places in the US or in the world, the wait time for adenotonsillectomy is much longer. So this study was trying to determine what is the risk of this delay time in management. And this study looked at almost 500 children that were diagnosed with sleep apnea. And interestingly, they didn't take the very severe. So they excluded kids that had AHI higher than 30. They divided them into two groups. The early tonsillectomy, these kids got adenotonsillectomy relatively soon after the diagnosis, and the watchful waiting, which they waited 7 months until they repeated the sleep study and then performed the surgery. So we have the both groups underwent polysomnography, sleep study, as well as cognitive and behavioral assessment. So the cognitive and behavioral assessment was the primary measurement of this study. So the kids that got the surgery, a month after the surgery, had repeat sleep study and repeat behavioral assessment, whereas the watchful waiting group, they waited 7 months, they repeated the cognitive behavioral assessment and repeated the sleep study. And that study showed some pretty amazing results. First of all, the NEPSI is a cognitive study that is done with a psychologist in the room testing the patient directly. So that study didn't show a difference between kids that had a tenotonsillectomy and the kids that were on the watchful waiting group. But all the other testing, so testing that is done by questionnaires, either for the parent, the caregiver, the teacher, all those showed significant improvement after surgery. So the Connors rating scale and the teacher reported data all significantly improved after surgery and were unchanged in the watchful waiting group. In terms of sleep in terms of the sleep study, there was overall improved in apnea-hypopnea index in the adenotonsillectomy group. There was improvement in oxygen saturation. There was improvement in CO2 levels. What was striking is that even in the watchful waiting group, almost 50% of the kids improved on their sleep studies. So we had 80% improvement, or 80% normalization or cure in the adenotonsillectomy group, but 50% of the watchful waiting improved as well, which changed what I explained to parents when I talk about surgery. In later studies, in further analysis of these data, what they found is that even the 50% of kids that improved on the watchful waiting in the sleep study criteria did not improve on the behavioral cognitive part. So even though the numbers were better on the sleep study, their actually cognitive behavioral functions did not improve. So we're still doing adenotonsillectomy. Of course, there are high-risk groups, we already talked about them, where you don't see the improvement, the spontaneous improvement without surgery. And that includes African Americans, it includes obese patients, and it includes patients that had, coming into the surgery, had more severe sleep apnea. In those groups, you don't see the spontaneous improvement in general. Okay, so it's pretty clear that adenotonsillectomy is probably the most important surgery to cure obstructive apnea, but it's not 100% cure. And this is just one study, a really nice study that was done multi-center that looked at the cure rates of adenotonsillectomy, and they split the patients into kids that came in with mild OSA and the kids that came in with severe OSA. They further broke down the population to males, females, and obese and non-obese. And the general picture that we see from that study is that when children have mild sleep apnea, adenotonsillectomy provides cure in about 70% of the kids. Another 25% will have improvement, and there will be about 5% fail, so no improvement. When we look at the severe OSA group, about only 42% had cure of their sleep study. About another 40% had improvement, and 20% had a fail results. And this study pretty much created the recommendation of repeating a sleep study in children that had severe sleep apnea. So if the kid comes in with mild or moderate sleep apnea, we're pretty sure that they will improve or cure after surgery. But if they come with severe OSA, we really need to reassess that. So what are the other treatments that are available for obstructive sleep apnea? We talked about the sleep apnea being inflammatory state, so controlling inflammation throughout the respiratory system will improve. So treating asthma, treating allergic rhinitis, in younger kids, treating acid reflux, excuse me. Anti-inflammatory agents definitely shown to improve sleep apnea, specifically when we talk about mild sleep apnea and more for the mild residual obstructive sleep apnea, the kids that improved but didn't cure. We very often use intranasal corticosteroids, which decreases inflammation but also shrinks adenoids. And there's a body of literature about using Singular in these patients. Definitely weight loss in the obese population, but that it takes time, it's difficult, and it's also difficult to maintain. Oral appliances are a big part of treatment in the adult sleep apnea group. In children, we don't use it as much because we have patients that don't have all their teeth in their mouth, their teeth are still moving, and there's a high risk of changing the facial structure if you put appliances. But the two surgeries that the two interventions that we do use is the rapid maxillary expansion, which is what you see over here, especially for kids with high arch palate, which is a risk factor for sleep apnea. And the mandibular advancement surgery. And this is a surgery that we, here at Cornell, we kind of used in the past few years. Thankfully, we have a very talented oromaxillofacial surgeon who can really apply this surgery to very young children, really newborns. And we kind of collected our data. We described a case series of patients that had mandibular destruction osteogenesis, that had micrognathia. Most of those kids had Pierre-Robin. We had about 22 patients. We used sleep study to determine how much to advance the jaw to the point where the sleep apnea is resolved. So what traditionally the surgeons will do, they will put the appliances in place, and you can see the appliances here on the CT scan, and advance the jaw until cosmetically appropriate, so where the jaw should be. And at that point, they will take the devices out and leave the patient. What we do at this point is we have the surgeon advance the jaw to the point where where the jaw is supposed to be, and then we perform sleep study while the child is still in the hospital. And if we see residual sleep apnea, and in most of those cases in the very young children, we see residual obstructive sleep apnea, we ask the surgeon to continue advancement until we see improvement in the sleep apnea. And our criteria is apnea-hypopnea index of less than 5. So in most of our neonatal surgeries, we saw that just by appearance, the advancement was not sufficient. And we have some data already, kids that come back a year later, a year after the surgery, and we see that there is persistent results with, we don't see any evidence of upper airway obstruction. The surgery still holds. I think the images here are pretty striking. You can see the small airway in the baby when the jaw is very small, and after advancement surgery, you can see how nice the airway opened. Other surgical interventions that, again, we borrow from the adult world is the hypoglossal nerve stimulator. And you realize that we or you guys as surgeons, very creative in terms of surgery, because if adenotonsillectomy fails, we're pretty much looking at using CPAP on patients. And in children, success with CPAP is very poor. We really try to help these kids in different ways to try and avoid going for CPAP. So hypoglossal nerve stimulator, I know here at Cornell, there's a lot of experience. Dr. Sorna does it. I think Dr. Rosenblatt has as a research protocol will start doing it on children with Down syndrome. You guys know it better than me, but there's a sensor that is placed at the upper chest that measures the stretchiness or the hyperinflation of the chest. And when there's an increase in chest movement, it will send a signal to the nerve and will stimulate the hypoglossal nerve, which is the tongue, and the tongue will protrude forward, opening the oropharynx. And this surgery was shown to be very successful, and this is the milestone surgery that was reported in New England Journal of Medicine, where it showed significant decrease in apnea-hypopnea index and persistent results a year after the surgery. So again, this is could be a really nice tool. Doesn't require a compliance from the patient and has really good results. Other treatments that were described for obstructive sleep apnea is the myofunctional therapy, with the idea that the mouth and the faces of children are still malleable and they still move. So by doing physical therapy to the upper airway muscles, you can change the structure of the face and maybe improve sleep apnea. So this is the kit over here. It includes, I don't know exactly how it's done, but it includes a series of exercises of the tongue and the lips and the mouth. Surprisingly, I was the first one to roll my eyes when I heard that about that treatment option, but surprisingly, there is at least one study that shows improvement in the mild OSA group with that myofunctional therapy. So for those specific kids that have a upper airway issues, that could be potentially could be a treatment. High flow nasal cannula comes in now. It's usually used in the inpatient settings. It can provide some pressure, but in a very gentle way, and it's much better tolerable than CPAP. So high flow nasal cannula kind of now is available as an outpatient, and we use it for the younger children where it creates good pressure. I have to say in the older children, it doesn't create such a great pressure, and it doesn't really resolves obstruction. And then as a last resort, we do use positive airway pressure. We do have issues with compliance. There are some complications, even though they're mild and completely can be addressed and resolved. And they have really great outcome. You know, the kids that do use the CPAP, the similar to adults, you see a resolution of their obstruction. It's just to get those kids to tolerate it. And we do have CPAP clinic at Cornell where we like to meet the kids before they assign to have CPAP. We introduce the CPAP in a very comfortable way. We have a child life specialist on board. We have a sleep technician who is a CPAP specialist on board. And together we fit them with the right interface. We do it in an accepting way. So there's no like the first, no, I don't want that kind of reaction. And we continue to follow those families and do either behavioral intervention or troubleshooting on the equipment to try and help them keep using the CPAP and keep accepting it. At this point, I'm going to stop and ask if there's any questions.
So Haviva, I want to thank you very much for a outstanding presentation, and I'm glad we've got some time for questions because some good questions have been coming in from the chat. I do want to take this opportunity to thank Dr. Terabici for including us in this way in his program. It's a very nice program which he has put together, where there's educational lectures going out from really all over the world. through the Terabici-Stamberger Institute. And it's always been a pleasure to work with Dr. Terabici. I've worked with him for many years when he was on the editorial board of the Laryngoscope Journal and in other venues. But we're pleased at Weill Cornell and New York Presbyterian to join and be able to provide many of our Grand Rounds lectures live. So we'll be looking forward to seeing people in this venue with our Grand Rounds going into the future. And also I'm going to speak with Dr. Terabici about potentially including some of our case conferences and other materials. So thank you for including us, and we're pleased to be part of this. Several of our faculty have already lectured in your program, but we'll be doing our Grand Rounds going forward. And I'll turn it now over to Dr. Modi and ask him if he can moderate some of the questions that have been coming in for Dr. Veller. Can you unmute, Cash?
Okay, great. Good. I got unmuted. So one of the questions, Haviva, thanks for an excellent talk. Great overview of things, and also talking about some of the latest and greatest stuff we're doing with the polysomnography guided mandibular distraction. One of the questions that came from the audience was, what are your views on at-home sleep studies for kids? What are your thoughts on that?
All right. So at this point, the American Academy of Sleep Medicine and the American Academy of Pediatrics do not support doing home sleep testing for children. And the reason is twofold. One is because in older children, you do get reliable testing, so you can analyze the data. In the younger children, usually we talk about before first grade, the data that is coming, and there's a nice study that was done, I think 3 or 4 years by Carol Marcus, who unfortunately passed away, that showed that when you get the study back, there's always one channel that is off. You don't get the information about the whole night. Oxygenation is not measured all night long because the kids throw off the monitor at some point. But the bigger problem, the bigger picture is the fact that when we talk about the apnea-hypopnea index in children, we talk about very low numbers, right? An index of 10 is already severe. And we know that when we use the home sleep testing, there is definitely underestimation of the apnea-hypopnea index because we don't have, I know devices get more and more sophisticated, but most of them would not give us EEG information. So we don't have information about arousals. And in that sense, we underestimate the hypopneas. And we already said in kids, we usually get hypopneas. We don't get like the true nice measurement of apneas. And that's the reason that the apnea-hypopnea index is getting underestimated. And you can imagine that if we underestimate in 5, we're already, assessing the kid as a mild OSA, whereas he has severe OSA. So that's the reason we do not support home sleep testing for children. Of course, when we talk about adolescent, maybe it will be more relevant, especially the obese adolescent. But for the younger kids, not at this point.
Great, thanks, Aviva. Another question we had was, typically, when do we repeat sleep studies after surgery? And that's something Aviva and I have been working together as far as, when do we do it and do we repeat the sleep study? So go ahead, Aviva. If you want to comment on that, I can comment as well.
Right. So we already talked about kids that are high risk for persistent or a not complete cure from adenotonsillectomy. I think we definitely repeat the study. So kids that come in that are obese, kids that come in with severe sleep apnea on the initial sleep study, and kids that have other high risks. So kids with Down syndrome, craniofacial abnormalities, a neuromuscular weakness. This will be the kids that we will repeat the studies. One more word about a adenotonsillectomy. These are also the kids that tend to have more complicated course after surgery. So at Cornell, what we do is we have a OSA protocol that anesthesia has. They with more careful observation and longer observation after surgery, and also some of them will keep overnight in a monitor unit because we know they will have more complications. And then, of course, you know, the kids, sometimes you'll have the kids that improve and then get worse, like the first case that we described. So those are the kids that I would recommend repeat studies.
Okay, I had a question also, Habiba. This question came up in the chat, and that was related to low resource countries. We have some attendees here who don't have access to sleep studies, probably for adults, much less for pediatrics. Certainly in the US, which is a high resource healthcare country, pediatric sleep studies are not easy to attain, even in many areas of the United States. And certainly I know that's true in other parts of the world. What would be your criteria for if you have very limited access to sleep studies, who should get them in pediatrics?
It's a good question. So some sleep physicians, so you know, researchers in the world of sleep, pediatric sleep, are trying to come up with other means to diagnose sleep apnea. And, you know, there was a lot of effort in trying to use questionnaires as a guidance, to use overnight just oximetry as a measure. And none of them was as sensitive as using polysomnographies. And that's why in the US, we still continue with the recommendation of doing the doing the polysomnographies. However, you know, I think David Gozal is one of the big researchers in the world of pediatric sleep. He came up with a criteria to diagnose sleep apnea that relies more on symptoms. So loud snoring, findings on physical exam, plus learning disability, hyperactivity, daytime sleepiness. So there are kind of other criteria specifically for areas where they cannot use the sleep study as a tool. There are other questionnaires or criteria that can help with that screening, at least, who are the more severe and needs attention right away versus the more mild cases.
Yeah, no, and just to be clear, even at our institution, I would say about 90% of children that get adenotonsillectomy do not get a sleep study. It's only the 10% of our cases that do get a sleep study. Those are where there's a discrepancy between what the physical exam is and what the parents are reporting, or if they've got other comorbidities. Those are the kiddos we're getting sleep studies on. Or like a child where, you know, they'll be 3 years of age, and when they go to sleep, the parent brings in a recording of Strider. Those are the kids where, you know, we're thinking about sleep-dependent laryngomalacia, and these are the kids we get sleep studies on. But the majority of our patients we operate on don't get sleep studies. I think there's you're muted.
There was a, oh yeah.
Dr. Riva, thank you very much for a very nice lecture. You know, one of my teachers, this is like some 30 years ago, he's passed away since, is a very experienced otolaryngologist. And what he used to say, he said, you know, he thinks that the hypertrophy of the tonsils and the adenoids are very important to mold the airway during those years of growth. And what he felt from his experience is that the more we do tonsillectomy and adenoidectomy, we will fix obstructive sleep apnea at an early age, but we create a lot of obstructive sleep apnea later on. Is there anything, does this hold water? Is there any data on that?
It's interesting what you say, because I mentioned that previous adenotonsillectomy was a risk factor for a sleep apnea. I don't know if adenotonsillectomy causes sleep apnea in the future. We definitely know, and you as otolaryngologists know, that the facial structure of a child changes. So if a child has chronic allergic rhinitis, his face will change. He will develop high arch palate. He can develop sleep apnea just because his nose is obstructed because of the allergic rhinitis. So I definitely think that we need to put a lot of thought before doing surgery to decide how, you know, who is truly will benefit from the adenotonsillectomy. Saying that, you know, research support adenotonsillectomy as the main treatment for obstructive sleep apnea in children, even in children that have other reasons for their OSA, so like the obese children or the kids with the a craniofacial abnormality, the neuromuscular weakness. So
You know, it's a
I
very
guess
interesting question that Dr. Terabici asks, and he and I both have enough gray hair. We remember these discussions changing over the years. There was a time when adenotonsillectomy was relatively routine in some countries. If one child was getting it, you would just go ahead and take the tonsils out in the other child so they could both recover at the same time. That was the thinking, because it might prevent future problems. And I think, at least in the United States, we've moved very much away from that. So routinely taking out tonsils and adenoids probably is not necessary. And perhaps in some patients, you are predisposing them to have airway remodeling, which could become a problem, perhaps. However, when they're hypertrophied and they're obstructing, it's hard to recommend leaving them in, you know, because it might take them out, might cause a problem. They are causing a problem, so take them out. And I think probably Dr. Terabici's teacher is probably correct at some level. Probably routine removal is not only not helpful, it may be harmful. Routine removal of normal sized tonsils and adenoids that are not causing problems probably is not necessary and may actually be harmful in some ways, but that doesn't translate into not doing surgery when they're hypertrophied and obstructing. But it's a very interesting question that's really evolved over time. So I think our time is up. Again, I want to thank everybody for attending. Thank you, Haviva, for a terrific lecture. Thank you, Moaz, for including us, and we'll look forward to seeing everyone at future events. Thanks.
Thank you very much.
Thank you very much. So we're gonna break for 1 hour, and then we're gonna come back with a lecture from Dr. Hamid from University of California. And he's going to talk about managing complications of chronic otitis media surgery. So thank you all, and I'll see you in 1 hour. Take care. Bye-bye. Thank you, Dr. Aviva.